So I'm very happy to be here with you all today, and I'm going to be talking today about some very practical applications of designing data inputs that matter in a learning health system that we've been building at the University of Michigan in the Department of Physical Medicine and Rehabilitation. So first, I want to acknowledge all the people that make this engine run. I play an important role, but I am not the only person at the table. So I'm going to tell you a little bit about this group as I go on, but I just want to acknowledge the people that really every day are working really hard to figure out how to do this, which is the journey I'm going to share with you, and really work very closely with the clinicians that are developing their learning health systems. And especially all of our team champions, which I'm going to tell you a little bit about what those are when I get started. So just the big picture view is we began this in 2018, and we launched this with an investment from the dean of our medical school. And we started with the goal that we were going to develop a learning health system that covered the entire department. Our department's about 70 faculty. We see thousands of patients a year. So this was quite ambitious when we started, but that was our vision, and that has remained our vision. By about 2002, in the last year or so, we really have started to gain momentum in how we do this and who we do it with and everything. And we hope that in a couple of years, it's really going to be an engine that is just running, and it really becomes the way we do business and the way that we think about the work that we do. So today, I'm going to tell you a little bit about how we work to design data inputs. I'm not going to talk about everything we do, but talk about that part in particular. So this is a roadmap of sorts. And I will say that when we began this work, we were really wandering in the desert. And we were wandering because there was no manual that told us what to do. We couldn't go to people, at least we didn't know who to go ask of literally how you do this in everyday practice. As we began to work, and truthfully, we went down some dead ends, but we eventually started having little glimmers of hope. And then we had a eureka moment or two, which is really where I'm going to focus today's talk on. And then I think it's fair to say we have pretty much come up with a method that works really well for us. And I do think a lot of what motivates sharing this is because we think it'll work for others, particularly because things can be modified to fit the sites or the organizational contexts that different people may be in. So when we began this work, we really anchored our thinking in this learning cycle. And this is from Charles Friedman, who is here at the University of Michigan and is the chair of the Learning Health Sciences Department, which is the first in the nation. And the basic idea of this learning cycle is that you begin with understanding practice and creating data from practice. And that really is capturing what's done in routine practice every day and turning it into data. And that moves into knowledge, and these are creating insights, and this can be done in various ways. And then taking that knowledge and informing practice, whether it's changing it, developing new interventions, or what have you, and begin the cycle all over again. So where we're going to focus is in the orange part about practice to data, but I wanted to give you an overview of the learning cycle as a whole in the way that we think about how to build this. And again, thinking very practically and what infrastructure is needed to build this. So for many of you listening, you probably already know that rehabilitation is a very diverse field. And our department, like many, covers a range of patient populations and problems and interventions and practices. So in developing our infrastructure, we needed to find the right balance between standardization, so we could repeat the same process over and over again, but had enough give and flex that we could accommodate different size learning communities. Sometimes there are 2 people, sometimes it's 1, sometimes it's 20, and very different populations and practices within our broader health system. And I wanted to also say that the term learning community is what's commonly used in the learning health system framework and a lot of the thinking and writing. We use the word clinical teams. It means the same thing, but it really resonates well with with the teams we work with, as well as our ecosystem. And so we've chosen to use that language. But I just want to make it clear that that's really what we mean when we say learning community, or when we say teams, we mean learning community. So when we began this work, and this was, there was an investment from the dean to do this work, is we developed an operations team. And in the very beginning, we have some idea of what we needed, but that really has grown over time. And this team, and I'm going to tell you a little bit about them, really is needed because we need diverse expertise, points of view, and all of this around this complex undertaking. So I am the faculty co-director. My co-director is the expert in business operations and oversees the analytics in our department. We have a project manager that keeps us on track. That's made a huge difference. And we have 2 data analysts. And one of our analysts is an expert in extracting data we use Epic as our health system medical record, and she's an expert in extracting those data. She plays a very important role. And we have a data analyst who builds Tableau dashboards so the teams can access their data quite easily and generate insights. So we didn't know we needed all this at the start, but this really has been a good combination of expertise, perspectives, and skill sets. And we've learned over time when we hand off work to each other and how we make sure we're all on the same page. So one thing I wanted to talk about just before I get into some of the details is one of the challenges in developing a learning system and talking about it, whether it's talking about it with leadership or your peers, is that it's really all the things. It's not research, it's not quality assurance, it's not just clinical care, it's not just operations, it's all the things. And so we've learned over time that we borrow methods, perspectives, sometimes resources from these different areas to bring it all together under this broad umbrella of the learning health system. So we're very careful about the language that we use. We avoid using too much language that over-identifies a certain aspect of this, because that ends up creating confusion, particularly as people are just getting used to thinking about things in this way. And we had a retreat in the very beginning in 2018, and we launched it with all the faculty. And one of the important things that we did was to understand, what were they worried about? What did they fear was going to happen when we started to do this work? And this was still at a point where we didn't really know actually how to do it day to day. We had some ideas. And one of the things that really came out was this fear that they would become glorified data collectors, and the researchers were going to come and take all the data and write all the papers and get all the glory. And so we understood really early that we had to be really careful about how we talked about things, who owned things. And the other point I wanted to make was that it's okay to disagree, particularly as you're forming your infrastructure and thinking about how to do things, that the language that we use and the perspectives that we have sometimes use terms that are interpreted differently, or there may be disagreement about how much one dimension, say it's research or quality assurance, affects the way that questions are posed or processes are developed. And we have had a number of times that we've disagreed or had to talk out how we were thinking about things. And I wanted to really emphasize that it's actually healthy to do that. It's okay to do that. You have to manage those conversations and also be careful about power differentials, about how things evolve and are built between all the members of the team, because all those perspectives are important. The challenge is to figure out when they apply and to what extent. So I wanted to talk a little bit about the way that we organize this infrastructure before I get a little bit more into the details of coming back to the data inputs. And so we have, as I've told you, we have an operations team, and we're really the people that day to day are doing this work. Every team has a group of people. And again, teams can be small or large. And we usually have a team champion. And this champion represents the interests of the team. They often have very deep expertise, not only of the organization and the practice, but of the issues and the understanding of the needs of the practice. And this is often when teams are quite large, and that's probably more than a handful of people. Again, we don't have a hard and fast rule about how we do this, but it's really practical, because if you have a team of 20, that's a lot to have at meetings and to have conversations. I'm going to talk a little bit later about consensus building, particularly around large teams. But the main thing is that in most cases, there is one person that is designated as a champion who is sometimes an ambassador for the team themselves, or they may be the ones to promote or sometimes nudge forward this initiative. So this is a very important collaboration, and I think it is also practical. So the clinicians are very, very busy. So having a team champion represent the interests of others really has worked well for us. So now I'm going to zoom out a little bit, and I'm going to tell you just briefly about the major components of the infrastructure we've built and the process that we do. Again, I'm just going to focus on the first two, the learning goals, which is the gears going from clockwise from the left, and the inputs of the data that are connected to the learning goals. After those inputs are decided, there is a process of building those either questionnaires in the electronic medical record, or it may be changing the way that documentation is done. That can be a variety of things. I'm not going to talk about that today, but that certainly follows once we've decided what's the content of the learning health system that is related to a specific learning goal. And then there is what follows is data extraction, and then the building of dashboards that enable the clinical team to access their data without having to know complex software or do any kind of statistics. The dashboards, and we use Tableau, are built to enable them to explore their data in a variety of ways. So I'm going to focus today just on the learning goals and the inputs of the data. And I also want to mention that there's an important role of IT. This should not be surprising. And like pretty much every academic medical center, we have an IT that really covers the entire health system. So they're not dedicated to our work. So we have to get in line like everybody else. This can sometimes delay progress, but this is simply a reality. And we've really made a concerted effort to develop relationships with who we call the builders. So when we have decided questionnaires or certain ways that we need things documented, we rely on them to do that. So it's very important to build that relationship for them to understand our goals, and that this is an iterative, ongoing process. And there are things that we simply can't control. There are many competing demands in these organizations, so we plan accordingly. But I just wanted to mention that they play a very important role in developing relationships. Sharing your vision of this is an important aspect of developing that infrastructure. So now I'm going to talk to you about learning goals. And this is really putting the learning into the learning health system. And one thing I want to preface this with is the importance of dialogue. And much of the work that I'm going to describe is really done through meetings, conversations, sometimes debate, and then using everybody's perspectives to really hone in on what are the important learning goals, what order should they come in, and what data are associated with those learning goals that really are meaningful and are going to enable the team to really address their learning goals and continue to improve their practice through learning. So we came up with what we call learning goals, which are conceptually, often they look like research questions, but again, back to my earlier point that using words that tied the work too much to one thing, particularly research, was really important. So we really think about these as learning goals, and these help with the scope and the boundaries of the work that is anchored to them that follows, and that includes data input and data collection and extraction and so forth. And this really helps scope the work because, as you can imagine, clinicians have a million questions and they're all good ones. And without trying to really define where we're going to start and what's attached to that, the goal, we really have to articulate these quite clearly. And again, data inputs flow from learning goals, so they're a really important first step. So when we thought about how to organize these, at least conceptually, we borrowed from Neidler. Many of you may know Neidler and their stages of research. And we took these and we rephrased them a bit. So we described them in terms of learning goals. And so from left to right in counterclockwise, they sort of follow a logical trajectory. They begin with exploration and discovery. And this may be understanding patients, certain aspects of care. And this is also almost always one of the first steps of the teams. And it's an important first step in trying to develop things like phenotypes or patient profiles. And these are often what teams are interested in doing, because this will help them think about who benefits most from their care, what are important aspects of their patients, and so forth. So this is a really important first step. The development and the efficacy stages really focus on either changes in practice, understanding if practice or interventions are effective, and if they are they more effective some patients than others, as well as just understanding current practice, and when changes are made, are they working as they're intended? And the final stage of scale up really is very long term. None of our teams are at this point. And that really is starting after probably years of doing it. Have practices or interventions been developed that could be scaled up to the field, to other settings, and so forth? So that's very long term. Most of the time, we are spending our time in exploration, discovery, development, and efficacy. So I just wanted to give you a framework, and this helps the teams kind of think about where might their questions lie along this continuum. It's not real strict. It doesn't have to be a perfect fit, but this helped kind of give an anchor to these conversations. So now I'm going to tell you a little bit about, I'm going to show you some examples from our teams. We work right now with about 10 different teams at various stages of development. And so I'm going to share with you the learning goals of 4 of our teams that are at various stages of development. And you can see here we have very different teams: pediatric concussion, adult concussion, pelvic floor disorders, and interventional spine. And you can see from these learning goals that, again, are articulated in conversations. Usually they're led by me. I am primarily an investigator. I'm used to having conversations about project objectives and important questions and so forth. So I guide the teams in this. When we have these conversations, we have our data analysts present and our operations co-lead present, who are able to help to answer some specific questions as we start to dive into the details, which I'm going to tell you a little bit in a moment. So you can see the emphasis is largely on who are our patients, and knowing enough to develop phenotypes or profiles or even just natural groupings of things. So at this point, one thing that I want to direct you to is one of my colleagues, Rachel Richardson, gave a presentation before this one, and she talked a great deal about phenotypes and existing resources that can be used for building data inputs that are anchored in maybe consensus-based terms and definitions that can really help set the stage for that scaling up that might come years later. So again, the emphasis here is usually on understanding who are our patients. And I will say, after doing this for several years, that I would caution anyone to not presume that this is obviously reflected in the medical record. There are certainly data about patients like ICD codes and demographics that do exist that are standardized discrete data. But what we found is many characteristics that are important for the practice are not captured by either standard forms or questions that every patient in the health system receives. So it really is a matter of building on those things that are likely to exist already, but really adding some nuance and specificity that is related specifically to the patient population and the practice of the clinic. And so, as you can imagine, in rehabilitation, there are lots of different kinds of patients. So there's overlap of basic demographic characteristics, but as I'll show you some of the data inputs that flow from these learning goals, you'll see there's quite a diversity that ends up being created because the team really feels the need for a lot of specificity that is really going to enable them to really understand their patients so they can go to the next step. So now I'm going to tell you a little bit about a couple of learning goals from some teams that were developed that really are focused either that are going to come down the line, so after the learning goal of who are our patients, or in one case, that's where they're beginning. So they're either going to develop an intervention to try with their patients that has been used in their colleagues at other institutions, or really understanding, is our practice working? Are people getting better like we're expecting? And if everybody isn't, are there some who are, and are there characteristics that we can start to understand of who gets better faster and so forth? So these are 3 examples of 3 teams. So the orthotics and prosthetic group are the ones that are beginning a little bit later. And the reason they're doing this is the orthotics and prosthetic department is very big and very diverse. And their team champion, who understands the practice and the people, really felt that in order to really gain traction in doing this, it would be important to begin with something that really was tangible and a proof of concept that could really begin to give the team momentum. And so where they wanted to start was this use of kind of a self-report card. And for patients who use lower extremity prosthetics, and what ways did self-report data, and this is socket comfort score, quality of life, identify unmet needs and guide treatment planning? So it's not really exploratory, it's really more in the developing an intervention and then seeing, does it work? For the interventional spine group, and I showed you their learning goal, their first one is, who are our patients? What are their characteristics? So next, they want to understand, how are they responding to standard clinical practices? How do our certain interventions impact health-related quality of life? When people have procedures, how do they feel about change over time? And then for adult concussion, this group in particular does a lot of work around exercise prescriptions, and they really want to understand, does supervised exercise, is it related to the trajectory of recovery after acute concussion? So they really want to know this. And then, is this kind of paired with their original first learning goal of who are our patients? Can they create patient profiles and what they learn in this goal here to the left to tailor exercise programs to improve outcomes? So you can see that in particular, that trajectory of 3 learning goals, who are our patients, is this relationship we think exists between supervised exercise and recovery help inform using the phenotypes that we may generate from that first learning goal, help us be more prescriptive? So you can imagine this is quite a lot of learning that would happen over a number of years, but each of these build on the previous learning goal. So this helps us scope the work of the data inputs, making decisions about data and measures and so forth, really helps scope it to carry that work forward. You can imagine that if we didn't articulate this, which is what we didn't do in the very beginning, it's just you are wandering around week after week and really not making any progress because you don't have something to hold on to. So these are examples of learning goals that really enable the teams to focus their thinking and build all the pieces that are going to get them to data to practice, data to knowledge, and then knowledge to practice, that learning cycle I mentioned earlier. So Now I want to talk a little bit about those inputs and how we think about what that means in our infrastructure and our processes. I want to talk a little bit about consensus building that we feel is a really important part of the whole learning health system generation. And also a little bit about selecting and integrated patient-reported outcome measures and some of the barriers and facilitators of that process. So this work, the learning goal is developed. So now we have to decide, well, what data are attached to the goal that we have to either generate, we have to create, or we can just take what exists. That's a lot of decision making. So ideally, the choice of these inputs that, again, are anchored in these learning goals is guided by common data elements. That's ideal. Doesn't always happen, but that's ideal, where they exist. You want to also help, we help guide teams think about the future. Now, this gets back to this presentation I mentioned earlier on phenotyping by Rachel Richardson. Really is, are there existing phenotypes that could be used to help identify how data may be generated or even just coded, that kind of have the big picture, the long-term goal in mind, that one day you're going to build a system that may be scaled up to other sites that treat the same patients. So having that big picture in mind does help as you're thinking about the generation of data inputs that are tied to the learning goals. So there are many ways to do this. Again, it depends on the nature of the team. The champion may be quite knowledgeable about what is needed. They may come up with a list and then seek the consensus of their teammates. And again, for smaller teams, it's much quicker. Usually you can have everybody at the table, and it literally is a conversation going through all the elements of data that help address the learning goal that was articulated. So again, these methods should be flexible, but have some sort of documentation and processes that everybody is on the same page. So one of the important aspects of doing this work is to integrate patient-reported outcome measures into everyday practice. And this, in the last couple decades, many patient-reported outcome measures have been developed. There's a bunch of them. Their translation into everyday practice has lagged, I think, more than the field expected. And part of this are just practical considerations, but also I believe that clinicians are very knowledgeable that they exist and they understand their value. But I would say that in my experience, making the connection, whether it's a learning goal, a data input, how it can be used in practice really does lag. I think there is more that we can do. And some people are doing really good work in this area to really support clinicians in not only deciding what measures are going to be useful, they're going to help me understand my patients and not overly burden them, but be useful in really addressing future goals that we may not have thought of yet. So again, like many things, we want to balance practicality with some degree of rigor in the selection of these measures. So for our group, what I do, because I am a researcher and I actually also have expertise in measurement, I make recommendations based on my knowledge of the field, my understanding of their learning goals, my understanding of what's important to their practice. And what I do is I will make recommendations. I literally write this up in a Word document, and I select measures that I think would be useful, that have good evidence of their validity, their reliability. And I propose these to the champion and sometimes the team, and then they select what's going to work with them. Not surprisingly, people make decisions based on not wanting to overburden patients. If this is going to give them information that they can actually make use of, that tell them something useful and meaningful about their patients. And also, sometimes they like a measure, but they're going to defer it. They're going to maybe put it in the future. And all of those decisions are fine. And the one thing I will say, the little bit of feedback for the teams that have been doing this so far is two important things. One is when patients take the time to do these patient-reported outcome measures, and it is acknowledged by the clinician in the clinical encounter. This has a great, tremendous amount of impact on the patient's feeling that not only are they interested in my experience and my point of view, they actually looked at it. So I would very much encourage anybody that if you're going to integrate these in practice, they must be actually used. Otherwise, it really can be demoralizing for patients. And the other thing I'll say is that when we build the interpretation of the scores, and we build mechanisms so they feed into clinical notes, this is just one more way that there is efficiency built in, and efficiency is an important part of making a lot of these decisions that really provides meaningful information. So I would suggest that including patient-reported outcomes in the development of a learning system, considering an important input, is really a key to building meaningful inputs and just an infrastructure that can provide this. I would say people that are primarily researchers or do a lot of research are well qualified to be able to guide teams in making selection of good measures. Unfortunately, there are a lot of options these days. So I want to tell you a little bit about how we managed consensus building on making decisions about patient-reported outcomes. So the way I always talk about this and think about this myself is there's two important aspects to think about. One is, what is the construct? What is it you want to measure? Away from the practicality and the measurement tool, but what is the idea? What is the domain or construct? Then you talk about, well, how are we going to measure it? And so what we did, I'm just going to show you an example of this with our spine team that had a little bit of overlap with musculoskeletal care. So it was quite a big group of people. It's probably about 25 people. And we needed a way to be efficient in voting on constructs and measures related, in this case, in this example I'm showing you, around quality of life and a few other important aspects of spine care, spine and MSK care. And we needed an efficient way to do it. And we needed a way that anybody on the team had an option to agree or disagree with a certain proposition. And so we began this in January. This was in January 2020, where we came together and we talked it through. So there we got some initial ideas about what aspects of health-related quality of life were important to the clinicians, which they felt was relevant to their care and relevant to their patients. And so we followed this with, in this case, a REDCap survey. It could be any kind of survey tool. And we did a series of Delphi surveys to ask them, do you want to include, in this case, if you can see in the upper left-hand corner, pain mechanisms? Do you want to measure it? And that was just thumbs up or thumbs down. And then there's two possible ways to measure it. And this was, again, generated primarily through the team champion, knowing there were certain measures that were commonly used that they might consider. So you can see here on the left-hand side, they could say they liked either the propositions or neither of them. They could download the versions so they could see what the items were. And again, this was just a series of questions: should the construct be measured? Is this a measure that you want? And if not, can you suggest an alternative? And you can see this is just an example from one respondent that they liked the constructs. They weren't too sure about the measures. And on the right-hand panel, the screenshot is asking explicitly about, referring back to the meeting on that January where we talked about health-related quality of life, and that we just lumped everything together. Do you want to measure these things? Yes or no? Do you want to use this measure? So this is just an example of how you can use Delphi surveys. Quite efficient, probably took 5 minutes, 10 minutes tops to do, but really gave everybody a chance to have a voice in the process. And so after that, we put together essentially a report. We made an infographic of what happened from all the voting. And you can see here that most of the constructs, everybody was on the same page. You can see there was a bit of, this is the middle panel. So the left panel is just the constructs. it was pretty good agreement. Opioid risk, there wasn't a lot of agreement, but pretty much agreement. The middle column is how the measures stacked up. Again, measures were offered, or they could propose an alternative. Very few alternatives were proposed. There's a lot of variability on agreement about the measures, as you can see in the upshot thing. And the part on the right is a little bit of how the people responding characterized themselves. And we went back and really asked specifically about opioid risk. And the bottom line was we couldn't get any consensus on that. So that did not advance to be included in the learning health system. And then we used the same sort of process for revising the intake form. And this, again, this is for the spine group in particular. And we revised it, and it was a big, long intake. And that would have taken a lot of work if it required coming together and sitting down and going through everything. So this is a good example of the team champion proposed a number of changes to the intake form and began with, as you can see in the upper left-hand panel, revised the intake form and created essentially subsections, and that people could vote. Did they need to know? It'd be nice to know, or they don't need to know. And this enabled us to quite quickly go through each of the proposed revised section, and look at the consensus around keeping it or deleting it. And at the end of this process, the intake form, which contains some standardized patient-reported outcome measures, really pared down to probably about a third of its size. So it became very specific, very streamlined, and everybody had a chance to vote. So those are two examples of how we used some conversation and Delphi surveys, which allow people to work asynchronously to make their voice heard about what ultimately populated their learning health system. So next, I'm going to talk to you a little bit about how we pair a learning goal with data inputs. And so I told you a little bit about the overall process. So it's developing a learning goal, consensus building, and so forth. So this is the learning goal for the interventional spine group, which I just explained how we came to a lot of the decisions. And these are the inputs that are connected to that learning goal. It's relatively straightforward constructs, nothing real surprising. And this was simply generated through primarily conversation about what were the measures, what were the pieces of data that would be connected to the learning goal. This helps keep, again, the scope of the learning health system not to expand too quickly. So I have a couple more examples I wanted to show you. This is pediatric concussion. Again, they wanted to know who are our patients. You can see their list way longer. And this is simply the nature of their practice. They're pediatrics, so there's more information that they need to know to help understand who is coming to their clinic. And the final one I wanted to share is the orthotics and prosthetics. Talked a little bit earlier about they are jumping right to really wanting to understand if they give patients a scorecard with certain information, is that going to help them identify unmet needs? So you can see here, most of their data inputs are self-reported information, because that's really what they want to know. If we use self-report data, is that going to help generate insight and identify unmet needs? So you can see here, most of their data inputs are patient-reported outcomes. And so I just wanted to show you these three different connections of learning goals and data inputs to give you a clear idea that they can be quite variable. They really should be tailored for the question, which is tailored to the practice and the patients that are seen in it. So I hope that gives you a good overview of how we developed infrastructure and process to do that. So now I'm going to tell you a couple other things about how we do this. So one of the important things that we learned was it wasn't enough to take minutes. Taking minutes helped, kind of perpetuated us wandering in the desert for a while. We needed a place to write all of this down. So we developed 2 templates, and these templates will be available to you in the materials that are associated with this presentation. And we really encourage you to use them and to promote, tailor them to your needs, share them with your friends, do whatever you want with them. We wish we had something like this when we started. So the first thing we create is a team charter. And this helps us identify who's the team, when the team began, when learning cycles. So you can see here in the upper box, there's a reference to multiple learning cycles. These are attached to learning goals. Those are articulated in section C. So I showed you some examples of that. And the reason for this is we expect there's going to be multiple cycles of learning. It's not going to stop at one question. And this charter also helps us document what is the scope of practice, who are the patients, what is the overall characterization of that. And then there are a few other elements, but the most important element is this is where the learning goals are written down. So we literally have this open when we have meetings with our teams, particularly when we start, and we just start writing. And the other document that I wanted to share is what we call a data analytics work plan. And this is expressly connected to the charter, and this connects all the nitty-gritty detail of each learning goal on the left in the charter, connects to a table that, again, has constructs and measures. So this is where all the information, the data inputs for each learning goal is articulated. And again, we have it open, we have a conversation, we start documenting it. And this continues to be iterated as the data analysts work with the team champion or the teams to really flesh out the granular detail of where are the data, what's the nature of the data, do we need to build the data, do we need to submit a ticket to IT, is there a change needed in documentation practices and what have you. So this document is continually updating, and each learning goal has an associated data work plan, analytics work plan. You can see in the section near the bottom that there's a clear delineation of what builds are needed, what data transformations may be needed, what are potential constraints. And this is where the conversations also begin is, what does that dashboard look like? What is the timeline for all this work? So using this kind of documentation, it's not rocket science, but it really isn't something that we latched onto early enough. So we are hoping that by sharing this, you will not have to wander in the desert like we did. So that really is our story. That's our journey over the last few years. I think it's fair to say that we really have liftoff, certainly in the part of the the learning goals and the data analytics plans. And we really are at a point where we have been developing dashboards. Teams are going to begin to use them, and we expect that we will continue to accelerate the work as we have finally figured out how to generate meaningful data outputs. So I want to thank you for your time today. You should feel free to reach out to me with questions, comments, anything you've done that you found successful. I think it would be wonderful one day if we have a giant repository of all the different methods, approaches, and documents that we use to help to promote a learning health system, particularly for rehabilitation. So thanks very much. I look forward to your questions.